Good morning. Today we have a presentation on a second part of topical infestations and infections. First part you discussed last month. There were three presenters. Dr. Diptaman Nandi is a first year DNB PGT at MR Bangalore Hospital, and Dr. Prosenjit Basu, first year DNB PGT at MR Bangalore, and Dr. Nilip is first year junior resident at PLS Hospital at Bikira Research. So today, moderator will be Professor Prashant Kumar Bhattacharya, who is Professor and Head of Surgery at Sagardattu Medical College. So, Diptaman, you can start. I can see your screen. Okay. Diptaman, you start. Diptaman, you have an issue?
Hello. Sir, I'm audible?
Yes, yes.
Sir, I'm audible?
Yes, you're audible. Start.
Mycetoma is a chronic specific granulomatous progressive destructive.
Slide change karo.
Sumanda, please continue.
Mycetoma is a chronic specific granulomatous progressive destructive inflammatory disease which involves the skin, subcutaneous tissue, and deeper structures. Next slide. Okay. The positive, sir, are the slides visible?
Yes.
Slides are visible.
The causative organism may be two fungi when the condition is called Mycetoma. When caused by bacteria, it is called actinomycetoma. The pathognomic feature is the triad of painless subcutaneous mass, multiple sinuses, and seropulmonary discharge. It causes tissue destruction, deformity, disability, and death in extreme cases. Next slide, please. Mycetoma, now little discussion about the pathogenesis of mycetoma. Mostly occurs in the mycetoma belt. This includes parts of India, Africa, Latin American countries. These zones are pelvic mycetoma belt. There are two types of mycetoma mainly, Mycetoma and actinomycetoma. These are caused by fungi or bacteria entering through a site of trauma, which may not be apparent. Hence, the foot is most commonly affected. It produces a chronic specific granulomatous progressive destructive inflammatory lesion. This results in tissue destruction, deformity, disability, and sometimes death. Now, the clinical presentation about mycetoma. As mycetoma is painless presentation, it is late in the majority of cases. It presents as a slowly progressive, painless, subcutaneous swelling, commonly at the site of presumed trauma. The swelling is variable in its physical characteristics. These are firm and rounded, soft and lobulated, rarely cystic, and is often mobile. Multiple secondary nodules may evolve. They may suppurate and drain through multiple sinus tracts. Next slide, please. The sinuses may close transiently after discharge during the active phase of the disease. Fresh adjacent sinuses may open, while some of the old ones may heal completely. They coalesce and form abscesses, the discharge being serous, serosanguinous, or purulent. Pain supervenes when there is secondary bacterial infection. Next slide, please. The common sites affected are those that come into contact with soil during daily activities. The foot in 70% of cases and hand in 12% of cases. In endemic areas, the knee, arm, leg, head and neck, thigh and perineum can be involved. Rare sites are the chest, abdominal wall, facial bones, mandible, testes, paranasal sinuses, and eye. In some patients, there may be areas of local hyperhidrosis over the lesion. Next slide, please. Lymphadenopathy is common. This may be due to secondary bacterial infection, lymphatic spread of mycetoma, or a local immune response to the disease. Constitutional disturbances are a sign of secondary bacterial infection. Cachexia and anemia from malnutrition and sepsis may be seen in late cases. It can be fatal, especially in cases of cranial mycetoma. Next slide. Now, about the spread of mycetoma. Spread can be local, which occurs predominantly along the tissue planes. Organism multicolonies, which spread along the facial planes to skin and underlying structures. Lymphatic spread is more common in actinomycetoma. It occurs to the regional lymph nodes and increases with repeated inadequate surgical excision procedures. Lymphadenopathy may also be due to secondary bacterial infection, and mycetoma can also spread via bloodstream. Next slide. Now, there are some differential diagnoses of mycetoma. Mycetoma should be distinguished from Kaposi's sarcoma, malignant melanoma, fibroma, and foreign body granuloma. The radiological features of advanced mycetoma are similar to those of primary osteogenic sarcoma. Now, some diagnostic procedures of mycetoma. First, there comes the plain radiograph. In early stages, soft tissue shadows, often multiple with calcification. As the disease progresses, there can be features of bone scalloping. In further advanced cases, periosteal reaction with new bone specules may create a sun-layer appearance and convex triangle, but it is not unlike an osteogenic sarcoma. And at the most advanced stages or late stage of the disease, there can be multiple punched out cavities throughout the bone. One minute. Now, next comes ultrasound. In ultrasound, ultrasound can differentiate between eumycetoma and actinomycetoma, as well as between mycetoma and other conditions. In eumycetoma, the grains produce numerous sharp, bright, hyper-reflective echoes. In actinomycetoma, the findings are similar, but the grains are less distinct. The size and extent of the lesion can be accurately determined ultrasonically, which is a finding that is useful in planning surgical management. MRI is another mode of diagnostic uh, uh, system which helps to assess bone destruction, peripheral reaction, and particularly soft tissue involvement. MRI usually shows multiple 2 to 5 millimeter lesions of high signal intensity fibrous tissue. The dot in circle sign, which indicates the presence of veins, is highly characteristic. Next up, CT scan. But CT scans are not very much helpful as they are not much specific, but helpful to detect early bone involvement. So CT scan can be used to detect some bone involvement in early stages. And now comes the histopathological diagnosis, which is quite helpful. Deep biopsy is obtained under general or regional anesthesia, although the chance of local spread is high. Then there is FNAC. FNAC can yield an accurate diagnosis and helps in distinguishing between mycetoma and actinomycetoma. This technique is simple, but it is rapid and sensitive. Next comes the culture method. The culture method helps to distinguish the textural description, morphology, and biological activities in pure culture of various types of mycetoma. In the absence of classical triad of mycetoma, the demonstration of significant antibody titers against the positive organism may be of diagnostic value and aid follow-up. The common serological tests are immunohistochemistry and ELISA. Now comes the management part. Ideally, this should be a combined effort between the physician and surgeon. In actinomycetoma, combined drug therapy with amikacin sulfate and cotrimazole in the form of cycles is the treatment of choice. Amoxicillin, clavulanic acid, rifampicin, sulfonamide, gentamicin, and kanamycin are used as second line of treatment. In mycetoma, ketoconazole, itraconazole, and voriconazole are the drugs of choice. They may need to be used up for a year. So these are prolonged therapy with these drugs. Medical treatment of both types of mycetoma must continue until the patient is cured and also in the post-operative period. Now comes the surgical treatment. Surgery is indicated for small localized lesions and resistance to medical treatment, or for a better response after medical treatment in patients with massive disease. The surgical options are wide, local, and debulking excisions and amputations. Amputation is used as a life-saving procedure, is indicated in advanced mycetoma, which is refractory to medical treatment with severe secondary bacterial infection. The amputation rate is 10 to 25%. Post-operative medical treatment should continue for an adequate period to prevent recurrence. The recurrence rate varies from 25 to 50%. This can be local or distant to regional lymph nodes. Recurrence is usually due to inadequate surgical excision, use of local anesthesia, lack of surgical experience, or non-compliance. So now we come to the summary of the whole part of our discussion. Mycetoma can be some features include or diagnostic path includes its presence late as it is painless. It is a triad of painless subcutaneous mass, multiple sinuses, and seroprominent discharge. Clinical feature may be deceptive as there may be deep-seated extension. It may spread to lymph nodes. It can be confused with Kaposi's sarcoma. Radiologically, can be mistaken for osteosarcoma. MRI shows typical dotted circle sign. Open biopsy and FNAC are confirmatory. Regarding the summary of management part, it is ideally combined managed by physician and surgeon. Medical treatment with appropriate long-term antibiotics. In large distance, medical treatment to reduce the size followed by excision. To be aware of serious drug side effects because medical therapy or drugs are given for a long time, so there can be some side effects regarding prolonged use of these chemotherapeutic agents. Surgery in the form of wide excision and amputation as life-saving procedure. These are some pictures of mycetoma. Number one is inguinal mycetoma involving the inguinal region. Then there is mycetoma of hand. And lastly, there is a mycetoma of limb. Thank you, sir.
I think you have
Prashant,
covered.
yeah.
Yeah, I think he has covered the topic nicely. Not much scope of asking questions. Um, what is a Madura food, by the way, Jitsuman?
Sir, Madura food, it is a, sir, this mycetoma infection, and it is, I think, a process is uh, applied after amputation surgery.
These
So actually,
these was first described in the place known as Madura.
Madura
This granuloma station. That's why it's called Madura food. And you have not mentioned about the different variety of bacteria causing actinomycetoma. There are different types of bacteria. There are number of strains. Okay.
Okay, sir.
And the discharge, the granules which are being discharged are also different in different types of infection. Some discharge may be white, some discharge may be black, some discharge may be yellow. So there is a chart saying that this particular type of bacteria or the fungus has this type of granular discharge. And you need to differentiate between the actinomycetoma and eomycetoma. Why? The differentiation between actinomycetoma and eomycetoma is important.
He has already mentioned.
Sir, actually,
why this differentiation is important? Is the treatment same?
So, treatment is slightly different because
not slightly, it is completely different. No, you said at the very beginning that one is fungal, other is bacterial.
Yeah, another is bacterial. So
the treatment is completely different.
Pathogenic organisms are different, so management or treatment will be different according to the pathogenic agent.
Yes, one is antibiotic, another is antifungal.
Antifungal.
So you need to differentiate. Okay.
Yes, sir.
So Madura foot is basically mycetoma involving the foot.
Yeah.
Okay, that is called Madura foot. You should have mentioned it. That is asked commonly. What is Madura?
Okay.
That is the eomycetoma caused by nocardia.
Yes,
nocardia species. Yes, sir.
Okay. We can pass on next presentation by Dr. Prosenjit Basu, who will speak on surgical manifestations of tuberculosis. It's a unique disease and it can affect any system in the body. And we often come across tuberculosis in our practice. So Prosenjit given overview of surgical manifestations of tuberculosis. Prosenjit, you can share your screen and present.
Sir, is the screen visible?
No.
No.
Hello, good morning, sir. I am audible, sir.
Yes, you are audible. Please start.
Sir, yes, sir. Tuberculosis. I am going to present the surgical manifestation of the tuberculosis. Please change the slide, Mohil. Tuberculosis is a systemic disease, but in our surgical confront the cervical lymph node and abdominal TB mainly. Abdominal TB classifications includes intestinal, which includes ulcerative, hyperplastic, perforatic, peritoneal, which classified further as wet, dry, aplastic, fibrotic, fixed, and acute primary peritonitis. Mesenteric involvement, which present as mass, abscess, or nodal involvement, or solid organ involvement, such as liver, spleen, and pancreas. Tuberculosis cervical lymph adenosis. This is a common condition at any age. A matted lymph node mass is a typical clinical feature. In later stage, the mass may be cystic, denoting an abscess. The abscess denotes underlying caseation and does not show any feature of inflammation. It's called as cold abscess. Ultimately, the abscess may burst, forming a sinus. Diagnosis is clinched by the culture of pus and biopsy of the lymph node. Involvement of other systems may be excluded. Treatment is mainly medical. Tuberculosis of small types are ulcerative, hyperplastic, and mixed types. Ulcerative, in which the virulence of organism is more than host. Serosa is studied with tuberculosis. Histology shows caseating granuloma with giant cells. Hyperplastic types are those in which host resistance is more than virulence of the organism. Thickening of the terminal ileum is marked. Stricture and fibrosis is pronounced. Here, the barium contrast study with ileocecal tuberculosis shows the Fleischer signs, in which the ileocecal valve is thickened and is incompetent, and conical cecum is there, and increased IC angle, ileocecal angle. Clinical presentation: intestinal obstruction, which may be acute, subacute, or chronic. In later stage, it may get perforate, and ascites, which is diffuse, localized, or organized, or lump or mass in the form of abscess, lymph node mass, bowel mass, ileocecal mass, or omental mass. The clinical features of signs and symptoms include weight loss, malaise, evening fever, cough, alternating constipation and diarrhea, and intermittent abdominal pain with distension. The abdomen has a doughy feel. A mass may be found in the right iliac fossa. The emergency patient present with features of distal small bowel obstruction, abdominal pain, distension, bilious and fecal vomiting, feculent vomiting. Peritonitis from a perforated tuberculous ulcer is a small bowel, can be other emergency. There are some basic investigation to diagnose raised inflammatory markers, anemia, positive sputum culture, interferon gamma release assay for subclinical infection. USG reveals localized area of ascites, chest X-ray show pulmonary infiltration, barium will follow through shows multiple small bowel stricture, particularly in the ileum with a subhepatic cecum, and genitourinary system reveals thimble bladder and golf hole ureter. And for the peritoneal TB, the less than 1% of all cases of TB, which includes 4% of extrapulmonary TB and 25 to 60% of abdominal tuberculosis. Forms of peritoneal TB include acute TB peritonitis present with pain, tenderness, vomiting, distension, chronic, which present in the form of ascites, encysted or loculated collection, purulent collection, and plastic form. Clinical features: insidious. It is insidious onset. Abdominal mass is doughy on palpation. Ascites may be there, and hepatomegaly. Inter findings includes multiple yellow-white tubercles less than 5 mm, studying visceral and parietal peritoneum, serosal surface, mesentery adhesion, matted bowel loops, omental thickening. Ascites may be there, and mesenteric nodes. A CT scan showing TB peritonitis, in which some ascites is there in paracolic gutter, and thickened peritoneum is there. Omental thickening is present, and multiple rim enhancing lymph nodes there. It is USG and CT finding of mesenteric TB. USG shows multiple enlarged lymph node in the mesentery, and contrast in a CT scan reveals infiltration of mesentery with presence of loculated ascites and thickening and enhancing of the peritoneum and rectoperitoneal lymph nodes. Thank you.
Kushanjit, you have not covered the subject well. you see, basically, primary tuberculosis is pulmonary tuberculosis, and extravascular tuberculosis is involving the most of the other systems.
Yes.
You started with cervical lymph node tuberculosis. So how does the infection reaches the lymph node in the neck?
Sir, it may be the source, maybe the pulmonary tuberculosis. It gets spread to
Very
cervical
important.
lymph node.
It
Yes,
can
sir.
be spread either through the pharynx or more commonly
The lymph node spread
secondary to
from
pulmonary tuberculosis. And what are the stages of this cervical lymph node getting involved by tuberculosis? There are some stages.
Yes, sir. Hello.
There are some stages of development of sinus. You said ultimately there is a sinus.
Yes,
So what
sir.
are the stages it goes through? Stage of lymphadenitis, stage of caseous necrosis, stage of abscess formation. It can be a colorectal abscess also. And then sinus or scaphonoderma. Okay.
Yes, sir.
Yeah, you have missed out many other sites of tuberculosis which are maybe of surgical importance. Like, for example, cutaneous tuberculosis.
Yes.
Hello, can
Yes,
you hear
sir.
me? Yeah.
Yes.
That is, cutaneous tuberculosis is something that is not too uncommon in surgical practice. Okay, can you name few of the manifestations of cutaneous tuberculosis?
Sir, ulcerated lesion.
No, they are specific names like tuberculous varicose cutis that mimics commercial carcinoma. Okay,
Yes, sir.
proliferative lesions involving the skin, most common in the foot. Then there is lupus vulgaris, scrofuloderma, as sir said. Scrofuloderma is when the abscess bursts and forms a sinus involving the overlying skin. That is called scrofuloderma. Okay, so these are
Yes,
not
sir.
too uncommon in clinical practice, in surgical practice. Along with that, there may be sites of the at the site of BCG inoculation, there may be also cutaneous tuberculosis. Okay.
Yes, sir.
Can tuberculosis affect rectum, anal canal?
Yes, sir. Can affect.
So it is not just
How?
small gut and peritoneal. Tuberculosis can affect the whole
How,
GI. It can involve the whole GIT.
Yes.
how does the anal or rectal tuberculosis manifest in clinical practice once again?
Tuberculosis may be confused with malignancy.
Yes.
You understand? Like you mentioned that there is a hypertrophic type of tuberculosis or there is a stenosing type of tuberculosis. So,
Ulcerative type.
okay, this can mimic malignancy.
Yes, sir. Rectal TB can manifest as a abscess or hemorrhoids or nodules.
Not hemorrhoid.
Not
Why should it be
hemorrhoid.
hemorrhoid?
It usually manifests as fistula in anal.
Fistula.
That's the
Yes.
reason why we should always send the fistula
One
tract for.
DD of renal fistula is tubercular.
Yes.
Yes.
Must always be sent for histopathology examination, rule out tuberculosis, and especially recurrent fistula.
You see, your topic was surgical manifestations. You should have brought out CNS tuberculosis also. That is also a
Yes.
surgical condition. Okay. The
Yes,
pulmonary
sir.
tuberculosis and its complications like empyema. Okay. There also a situation where surgery is needed. So you should have given a comprehensive idea about the extrapulmonary tuberculosis. Because see, most of the extrapulmonary tuberculosis are sometimes may need surgical intervention apart from antitubercular therapy. Okay, so given this more, you have confined more to the abdominal small gut tuberculosis. It can affect everything.
Yes, sir.
How do you confirm your diagnosis? You said that different radiological investigations. These are all supportive. How do you exactly confirm? Say, for example, abdominal tuberculosis. How do you confirm the tuberculosis? How do you send the specimen? What specimen would you like to collect?
Sir, in case of pulmonary tuberculosis, we said bronchoalveolar lavage to confirm and in case of abdominal TB, if ascites is there, we can go for ascitic tapping and send the ascitic fluid for AFB. Hello?
We can send it for cytology.
Cytological investigation, yes, sir.
Maybe lymphocytic predominance will be seen there.
Yes, sir. We can estimate the adenosine deaminase and compare it with serum ADA.
How much should be the ADA?
For abdominal TB, it should be more than 40, and for extrapulmonary, more than 50.
Anything to do with the ascites? Also, any other study that can be done? SAG?
Yes, sir. SAG can be done. It is serum albumin and ascitic fluid albumin gradient. It indicates exudative or transudative. In case of tuberculosis, we get exudative if it is less than 1.1.
Less than 1.1. Very good.
Yes.
Say there is mesenteric lymphadenopathy, which is a common, manifestation of abdominal tuberculosis. Okay.
Yes,
or peritoneal tuberculosis. How do you send the specimen?
Sir, mesenteric or peritoneal TB can be sent by on laparotomy. We can collect the sample.
And how do you send the specimen?
The samples are sent in a container with normal saline.
Yes, normal saline.
Normal saline, yes, sir.
How do you culture? I mean, then what you do with that specimen?
We centrifuge that, and then we go for microscopical examination for AFB finding to get AFB.
How do you culture?
By Jaden stain.
Culture.
Culture. Sorry. Loeffler.
Launstein Jensen.
Yes, sir. Launstein Jensen. LJ medium. Yes, sir. Sorry, sir.
Okay. Anything better that is available nowadays? Because LJ media culture, it takes some time, no?
Yes, sir. Yes.
Anything better than that?
Quick report. Backtech.
Yes, sir. Yes. Backtech can be done. Yes, sir.
What
or nucleoside and nucleic acid amplification test can also be done, sir.
Yeah, that can be done. What is MGIT? Any idea?
MGIT.
This is the medium that is nowadays used, and as far as the WHO guidelines, this is where it is available, of course. Otherwise, LJ media, as you said, yes, is Mycobacterium growth indicator tubes. There are tubes available.
Yes, sir.
Somebody said, yes, sir. You please explain to us what is MGIT. Hello. Somebody said yes. Okay. So these are tubes where, there are fluorescent material. This tuberculous bacilli, they consume the oxygen. This tube contains a media which is rich in oxygen, and when the specimen, say for example, the sputum is put into that tube, the bacteria grow and consume the oxygen, and as the oxygen gets consumed, then the fluorescent materials gets evident. So if a tube contains mycobacteria, after a while, the fluorescence would be evident. Understood?
Yes, sir.
This is called MGIT, Mycobacterium Growth Indicator Tube.
Okay, then we pass to the last presentation. Actually, RNTCP is very important. Our treatment regimen study the RNTCP, but recently there has been some change in RNTCP guidelines. So Dr. Nildeep is a first-year junior resident at Peerless Hospital and Bikarai Research Center. So he'll present on tubercular management and particularly the recent update in RNTCP guidelines. Dr. Nildeep, you can share your screen and start presenting.
Thank you, sir. Am I audible, sir?
Yes, you are audible.
Thank you.
Share your screen, otherwise.
Just for a while, sir. Is the screen visible, sir?
It's coming.
Yeah.
Okay. Okay. So
yeah, it's visible now.
Okay. So I will be mostly focusing the recent guidelines regarding the medical management of tuberculosis. So previously it was known as the RNTCP. Recently the guideline is named as National Tuberculosis Elimination Program, NTEP. So the recent logo of the program, NTEP, looks like this only. And the motto is TB Mukt Bharat. So as for the recent informations by the National Tuberculosis Elimination Program, India has the highest estimated burden of tuberculosis infection globally, with nearly 35 to 40 crores Indian population having TB infection, of which 26 lakhs people are estimated to develop tuberculosis disease annually. NTP aims to end tuberculosis by 2025 by reducing the mortality less than 90% and incidence less than 80%. As per the Indian TB report 2020, TB incidence is 188 per lakh of population, and the median age is between 15 to 45, and incidence is more in male. I have shown the age to sex pyramid for the TB notification, and it is the latest one, which was published in 2021. So we can see the median age of the affected individuals, which mostly, sorry. Excuse me, there's some technical issues. Oh, sorry. So that first I will be focusing on the diagnosis for presumptive TB cases, and I would like to mention the definition of presumptive TB cases. Any person with complaints of cough or fever or night sweats for more than 2 weeks with significant weight loss is considered as presumptive TB cases. So previously the guidelines said that sputum test with chest X-ray was the first line of investigations which we should order. But recently in the guideline 2021, universalization of nucleic acid amplification test NAT is advised. And see, as far as nucleic acid amplification test is concerned, CVNAT or TrueNAT can be done. Depends on the facility available in the center. Obviously, CVNAT would be more preferred than TrueNAT. And if CVNAT is negative, TB is ruled out. There is no chances of tuberculosis disease, active disease present if if the CVNAT is negative. In case of an NAT or sputum positive case, next what we should look for is the rifampicin sensitivity, which we can get from nucleic acid amplification test only. The rifampicin sensitive cases are treated with drug sensitive regimen, which I will be focusing in the next slide. If the rifampicin sensitivity comes to be resistant, in that cases, we would next do the line probe assay, which is further categorized into first and second line proboscis. In first line proboscis, we mostly look for isoniazid resistance, and in case of second line proboscis, we mostly focused on the group A and group B drugs. And depending on the results, patients are further categorized into isoniazid mono or polyresistant, rifampicin resistant, multi-drug resistant, polydrug resistant, pre-XDR, and XDR, which is extensive drug resistance. Drug sensitive cases, if becomes defaulter, again tested for LPA. First line for isoniazid, and as I mentioned, second line for group A and B drugs. Now, I would like to add few definitions like that I mentioned, which is presumptive MDR. Presumptive MDR means, which I am extremely sorry that I couldn't incorporate the point in my slide, but I would like to explain further. Presumptive MDR suggests if someone is taking anti-tubercular regimen for more than 1 month and default more than 1 month. This is a case which is considered that the patient is lost to follow-up. Secondly, currently the second scenario would be currently patient is on ATT, but there is poor response. That means no clinical improvement, or even after the treatment, sputum is still positive at 3rd or 5th month of follow-up. Third scenario would be any contact of multi-drug resistance case. Another scenario can be recurrent TB. Cured, that means the patient is cured after ATT, but now microbiologically once again confirmed to be a sputum positive case. So these 4 scenarios are considered to be presumptive MDR. So now I will be focusing on the treatment. In the drug sensitive TB regimen, which I mentioned earlier, the standard treatment protocol is treatment in 2 phases, that is the intensive phase and the continuation phase. Intensive phase consists of treatment of 6 months with 4 drugs, which are H, R, Z, and E, and 4 months, which is continuation phase with H, R, and E. Now the things which have changed, the guidelines recently changed during the 2021 guidelines. The previously resistant cases of integrated resistance cases has now suggested to be treated in a single regime, which is called integrated drug resistant TB regime. So I have incorporated that whole flow chart in 2 next slides, but I am explaining the same. In a presumptive case of multi-drug resistant TB, if rifampicin and isoniazid are both sensitive, then the standard drug sensitive TB regimen is used, which I have mentioned consists of 10 months of treatment. But if during NAT we found that rifampicin is sensitive, and in the next line, when we perform a first line probe assay and find isoniazid to be resistant, we will next go for a second line assay, and isoniazid mono resistant TB regimen is started, which is mono DR TB regimen. And if the rifampicin comes resistant, both first and second line LPA done to find the further sensitivity of the drugs. So in case of isoniazid resistance, there can be 2 genes. The CAT-A gene. Hello, am I audible?
Yes, yes.
So now we will look for two gene sensitivity, and if single gene is resistant, then we will consider the case to be monogene resistant tuberculosis, and if 2 genes are resistant, then the case is considered to be polygene resistance. Now, this is the flow chart of the treatment which has been incorporated in the recent guideline. So I have simplified the rifampicin sensitive case, which is this slide. And if rifampicin comes to be resistant, then The same thing is once more performed, that line probe assay first and second, and we will look for, this is the slide. So previously, as I mentioned, the two genes are INHA and CAT gene. So if one single gene is resistant, then it is considered to be a single gene or monogene resistant tuberculosis. And in that case, a shorter oral vidaquiline regimen is advised. And in case of both gene mutation, in that case, another regimen, which is considered called as a longer VDQ regimen, is advised. I have mentioned the drugs in the regimen in the next slide. So this is the drug sensitive, as I mentioned, primarily intensive. Actually, the slide is saying to be intensive phase of 2 months. This is wrong. Actually, it would be 6 and 4 total. As far the recent guideline is concerned, it would be of 10 months. But however, the drug is as same as before. HRJD in intensive phase and HRE drugs in continuation phase. And as far the rest of the scenarios are concerned, in case of isoniazid mono or poly drug resistance, Z, E, R, and O, these drugs are used. And in case of shorter MDR regimen, which I mentioned, in intensive phase, clofazimine, isoniazid, levofloxacin, vidaquiline, and ZD along with etomidate. And the longer, as far as the longer MDR TB is concerned, this 5-drug regimen is used. That's all for the medical management, I believe.
Yeah, you have once again done it very nicely. There's hardly any scope of asking questions. Just tell me the dosage of different drugs. This is sometimes asked in the examination in the form of milligram per
and the
kg.
dosage, again, you have supposed to mention that the revised guidelines say that it is not a intermittent therapy. It's a fixed daily dose therapy.
Yes, sir.
It's now fixed daily dose therapy.
Fixed daily
yes.
dose therapy.
Yeah.
Actually, sir, recently a fixed dose combination chart has been advised, which is different for. And sir, I didn't mention it, but this is the there is 2 different charts for adults and children, and where a fixed dose combination is mentioned. For isoniazid, it is 70. As far for the adults, it is 75 mg. For rifampicin, it is 150 mg. And
what we want to know is the milligram per kg body weight. INH should be given as.
Yes,
so
sir,
remember 5, 10, 15, 25. INH, rifampicin, ethambutol, and pyrazinamide. It is easy to remember that way. 5, 10, 15, 25. So 5 milligram per kg daily INH, 10 milligram per kg daily rifampicin, 15 milligram per kg daily ethambutol, and 25 milligram per kg pyrazinamide. So with this, but now this formula, you can automatically find that what sir said about the 6 drug combination, that will fit in according to the body weight.
Yeah.
Okay.
Okay, sir. Okay, sir.
The fixed dose combination I'm mentioning is depending on the body weight, they say 2 tablets or 3 tablets or 4 tablets.
Yes.
Yeah.
Okay. Is there a situation that you need to continue the intensive phase for longer period? Standard intensive phase is 2 months.
Yes.
Any situation where intensive
now,
phase.
what he said just now is that 2 month has been changed.
Yes, sir.
From 2 months to, he said, for 6 months. He said, right? 6 or 4 months. 6 months.
Yeah. It is 6 months, sir. 6 months for drug sensitive TB case. or a presumptive case. Previously, which was a period of 2 months, it has changed into six months.
Now, what sir is asking you is, in what situation will this duration, in what situations this duration might require to be increased? What type of tuberculosis? Where understood?
These are mostly of pulmonary tuberculosis. In extrapulmonary tuberculosis,
Yes.
the duration of treatment may be prolonged.
Okay, sir.
And
Like
what about second line
musculoskeletal
drugs?
tuberculosis.
What about second line drugs? Second line drugs?
Name the second line drugs.
The
Just
second
mention,
line. Yes, sir. Are you asking about the injectables? Like
injectables is one, but apart from that, there are a number of kanamycin. Okay.
Yeah,
cycloserine.
The ones that are used in drug-resistant tuberculosis. Yeah, MDR tuberculosis.
Sir, like linezolid, levofloxacin, clofazimine, cycloserine.
Yeah.
Yes.
Even the aminoglycosides, as I said, those are also considered to be
now it is said that streptomycin is replaced by amikacin. Now in the national program, the streptomycin is replaced by amikacin.
Okay, sir.
Yeah, the new guideline has to be followed now because the old guideline has almost changed.
Yes.
What should you, when these patients are taking drugs, as a clinician, what should you advise? Like, for example, you have said in the intensive phase 6 months, you tell them to come back after 6 months to you, or you tell them something?
Sir, follow-ups are mandatory. Like as previously in 2021, NTEP DOTS protocol was introduced. In that case, we have to call in a certain number after taking drugs.
Yeah.
So that's how patients were monitored. But as far as the follow-ups are concerned, we should be like asking the patient to revisit after 2nd and 6th month. Like after 2nd month for the next line of, we will repeat that screening tests, and after 6 months, whether the patient is complying with the treatment and also the success of the treatment, we should determine like with
exactly
repeating the sputum test.
Very good.
And also the chest X-ray, the prognosis we monitor.
And anything else? Because these drugs are very toxic.
So also the adverse drug reaction.
In hepatic dysfunction, which drug should be withdrawn? Hepatic dysfunction.
Sorry, sir, I couldn't.
In hepatic dysfunction, which drug should be withdrawn?
Hepatic for hepatic rifampicin and pyrazinamide.
Yes, rifampicin.
Rifampicin. And which drug has some ocular toxicity?
Ethambutol, sir.
Ethambutol.
So these are very important to monitor the patients from that point of view as well. From that angle, whether they are developing any side effects.
Yes, sir.
You have to monitor the enzyme levels. Okay.
Yes, sir.
ALT, AST has to be monitored.
Okay, sir. The LFT, yes.
Okay. Any more comment?
No, I think we have covered it nicely.
Okay. Thank you very much. Thank you all the speakers. Thank you, Dr. Bhattacharya.
Thank you.
Thank you, sir.